Good afternoon, everyone. I am glad to get this opportunity to present before all of the highly knowledgeable and reputed physiotherapists. My topic for the presentation is effects of combining two techniques of non-invasive brain stimulation in subacute stroke patients. The research was performed as a pilot study in Thailand. This study explores the use of NIBS, that is non invasive brain stimulation, to improve motor recovery in patients who have suffered a subacute stroke, that is, within 3 months of the stroke. The specific problem these patients face is weakness or reduced function in their upper limbs, a common stroke consequence. Traditional rehabilitation methods like physical and occupational therapy are often effective but have limitations like longer duration required for the treatment, financial crisis, etc. The researchers wanted to see if combining two brain stimulation techniques, that is, repetitive transcranial magnetic stimulation (RTMS) and transcranial direct current stimulation (TDCS), could boost recovery more effectively than either technique alone or standard rehabilitation. NIBS is a method that stimulates the brain without surgery using electrical or magnetic fields. The idea is to alter brain activity, especially in areas that control movement. For stroke patients, stimulating the motor cortex, the part of the brain responsible for voluntary movement, could help them regain control over their affected limbs. The techniques used in study are RTMS. RTMS uses a magnetic coil that creates brief magnetic pulses. These pulses pass through the skull to stimulate the brain. Specifically, low frequency RTMS with a frequency of 1 Hz was used in this study. The goal of low frequency RTMS is to reduce activity in the non lesioned hemisphere, which is the side of the brain opposite to where the stroke occurred. Usually, after a stroke, the non lesioned side of the brain may become overactive, disrupting the balance between the two sides of the brain. By reducing the activity on this side, that is, on the non lesioned side, the brain can regain balance, improving the functioning of the lesioned or damaged side. The second technique they used was TDCS. TDCS involves placing electrodes on the scalp and applying a weak electric current. In this study, cathodal TDCS was used. Usually, it has a similar function to low frequency RTMS only. It reduces again the excitability in the brain. It was also applied to the non-lesion side to further suppress its activity, complementing the effects of RTMS. Both of the techniques, that is RTMS and TDCS, work by reducing activity on the unaffected side of the brain, allowing the affected side to have a better chance to rebuild connections and regain control over movements. This makes the patient's rehabilitation more effective. Now we come to the methods that have been used in this pilot study. So, they have taken 10 subacute stroke patients who gave written or informed consent to participate in this study after having their stroke confirmed by either CT or MRI at the Rehabilitation Medicine Inpatient Unit at Maharaj Nakhon Chiang Mai Hospital, that is in Thailand. Inclusion criteria for the patients was that the age should be between 20 and 80 years and the stroke diagnosis has to be within 3 months, and the patient should have the ability to follow instructions in 2 consecutive steps. Exclusion criteria, they considered that the people with a history of either recurrent stroke or non-CVA, for example brain tumors and brain injury, unstable medical conditions such as uncontrolled arrhythmia, acute coronary syndrome, congestive heart failure, end stage renal disease, many of the diseases like pneumonia, UTI, or if the patient is already in use of a neurostimulator such as vagal nerve or deep brain stimulator, or if the patient is having pacemaker or metal in the skull or ear, if he or she is having a history of epilepsy, seizure within 1 year, such conditions, if they were noticed, the patient or the patient was excluded. Now, to assess the neurobehavior, case report forms including In the case report form included data on age, gender, stroke type, time post stroke, like how much time has been passed after the stroke, MRC scale for upper and lower extremities, that is MRC UA and MRC LE, Brunstrom stages for arm and hand, and FMA, that is Fugl-Mayer upper extremity motor score. Additionally, a 33-item upper arm function evaluation, which had a score of 0 to 2 with a maximum of 66 points, was also conducted. The WMFT, that is Wolf Motor Function Test, it also assessed hand and arm functions across 15 activities with scores ranging from 0 to 5, and the maximum points were 75, and the performance time was recorded. The study was a RCT, that is randomized controlled trial, meaning patients were randomly assigned to two groups. One of the group was an active treatment group and the other one was sham placebo group. Active group was given both RTMS and TDCS. RTMS protocol was 1 Hz stimulation was applied for 20 minutes using a figure of 8 magnetic coil. The stimulation was targeted at the motor cortex of the non-lesion site. TDCS protocol was given immediately after the RTMS. Cathodal TDCS was applied at an intensity of 2 mA for another 20 minutes. One electrode was placed over the motor cortex and the other was placed over the supraorbital area, that is above the eye. After both of the stimulations, the patient received 45 minutes of occupational therapy as part of their standard rehabilitation. Now, in case of sham group, the group underwent the same procedure but with fake stimulation, that is no real current or magnetic pulses were given. This helped control for the placebo effect, where patients might improve simply because they believe they are receiving the treatment. Both the groups received these treatments for 20 minutes followed by standard occupational therapy. This therapy is essential in stroke recovery because it helps patients practice the movement they need to regain function in their daily lives. If we talk about the instrument or the modalities, the TMS machine used was a MagPro R30 with option, manufactured by MagVenture. And while performing the RTMS session, first the RTMS dose, like what frequency we have to give was needed to be calculated. So during the RTMS session, another trained physiatrist who was certified for performing NIBS found the resting motor threshold in the contralesional hemisphere. And what actually we mean by resting motor threshold or RMT, it actually indicates the minimum intensity of the stimulation that produces 3 out of 5, that is more than 50% successive trail of 50 microvolt motor evoked potentials, and this is measured by surface EMG at the contralateral abductor pollicis brevis muscle. RMT was used to calculate the optimal parameters for RTMS stimulation for each patient. Two scales were considered as outcome measures to evaluate how well these treatments have worked. The two key tests were Fugl-Mayer assessment for upper extremity, that is FMA-UE. This is a standardized test that measures motor function in the upper limb. It scores different movements like wrist and hand function to quantify a patient's motor recovery. The other test that was used for Wolf Motor Function Test. This test measures both the time it takes to perform specific movements like lifting objects and the quality of those movements. It includes 15 different tasks as picking up objects or extending the arms, etc. Both the tests were administered before the treatment, immediately after the treatment, and again 1 week later to see if there were lasting effects. Now, in addition to these key motor function tests, that is FMA and WMFT, there were other scales also which were used to get a complete picture of patients' abilities and recovery. But these scales were used as a data for general assessment, not for comparing the effects or anything like that, but these were just used to get the patient's complete picture. The first test was Medical Research Council scale, that is MRC-UE for upper extremity and MRC-LE for lower extremity. The MRC scale is a quick and simple way to check how strong a patient's muscle are. They used it to see how much strength patients had in their arms and legs, which is important for recovery. After the treatment, they looked for changes in the strength also. Now, the second scale or the second data that they uh, cal- calculated was Brunstrom stages, that is for arm and hand. The Brunstrom stages help us to see how a stroke patient's movement is coming back. We start from no movement at all and track how they regain control of their arm and hand step by step. It's a great tool to see where they are in their recovery process. Now, functional ability and performance test, that is WMFT for functional ability score and WMFT for performance time. Two tests were considered under Wolf motor function test. Then a neurobehavioral testing was done to fully understand the patient's condition. The study also recorded basic neurobehavioral data, that is age, gender, type of stroke, if it is ischemic or hemorrhagic, and time since stroke. These factors help in understanding the baseline difference between patients, which can influence recovery. In terms of statistical analysis, the researchers employed two approaches to compare the outcome measures. First, they used the independent t-test to compare measures such as Fugl-Mayer assessment and Wolf motor function test between the experimental and control groups, which is usually the conventional method we all go for such comparisons. Additionally, to analyze the value at three different time points, that is pre-treatment, immediately after the treatment, and 1 week post-treatment, they applied a two-way repeated measures ANOVA. This test is basically designed to compare the means of groups across two different factors while accounting for the fact that the same subjects are measured multiple times under different conditions, and this offers a more detailed understanding of changes over time and between groups. Now, coming to the results, multiple tests were statistical analysis tests were done to check what kind of results they were getting. So after performing statistical analysis, it was gained that Fugl-Mayer assessment for upper extremity, the active group showed significant improvement in the FMA score both immediately after the treatment and 1 week later also, indicating that their upper limb motor function had improved. In contrast, the sham group did not show much improvement, suggesting that the brain stimulation techniques were responsible for the recovery. WMFT test, if we consider this, there was a trend toward better performance in the active group, but improvements weren't statistically significant if we compare them to the sham group. However, the researchers noticed that the active group seemed to complete tasks faster and with better functional ability. All the treatments were safe with minimal side effects. Some patients in the sham group reported headaches and minor discomfort, but these symptoms were mild and disappeared within a day. No serious side effects like seizures were observed. As you can also see in figure 1, if we see FMA assessment was done at 0 day, that is before the treatment, 1 was immediately after the treatment, and FMA 2 was 1 week after the treatment. The solid line indicates the values of active group and the dotted line indicates the value of sham group. So we can easily make out from the graph that the active group is showing significant improvement if we compare it with sham group. Same is in the case of WMFT, that is Wolf motor function test. We can see the improvement in active group better than the sham group. In figure 3 we can see that the performance time is reducing in case of active group if we compare it with sham group. So the study demonstrated that combining RTMS and TDCS can significantly enhance motor recovery in stroke patients by rebalancing brain activity between the two hemispheres. The neuroplasticity theory suggests that repetitive stimulation may encourage the brain to form new neural connections or strengthen existing ones, which can aid in recovery. One interesting fact is that while previous studies focus on applying these techniques over several weeks, this study showed a single session could provide noticeable improvements. This is important because fewer sessions could reduce the cost and burden of stroke rehabilitation for patients. This pilot study demonstrated that combining RTMS and TDCS is an effective, safe, and potentially more efficient approach to enhancing motor recovery in subacute stroke patients. Although the sample size was limited in this study, the findings are promising and lay the groundwork for larger studies to investigate how this combination could be incorporated into standard stroke rehabilitation protocols. In summary, the combination of RTMS and TDCS helps restore balance to brain activity after a stroke, offering the affected site a greater opportunity to recover. The study revealed that even a single session can significantly improve hand and arm function in stroke patients, a breakthrough that holds exciting potential for future rehabilitation efforts. The treatments were well tolerated, and the results suggest that these techniques could have a meaningful impact on stroke recovery moving forward. Thank you. If any one of you have any doubt, you can please post it in the group. I would be very happy to clear those doubts. Now, at the end, I would like to thank Harpreet sir for giving me this great opportunity to present this presentation in the group and helping me out throughout the procedure. Secondly, I would like to extend my heartfelt gratitude to Fayaz sir for his unwavering support and guidance during the preparation of this presentation. Like when I posted the audio files in the group, he took his precious time out and guided me and corrected me wherever the modifications were needed and cleared my doubts which I didn't understand in the presentation. And then after modifying, when I reposted the audio files to him, then again he just checked them out and told me what all more modifications are required. I'm highly grateful to him for teaching me the things that I didn't know. And thank you all of you for taking your time out to listen to this presentation. Thank you so much.